I've put the money slide at the very start, all right? So we're talking about vasopressin, steroids, and epinephrine for cardiac arrest. And what this paper that we're talking about did is the people randomized people to a standard care model versus this new model of drug treatment during cardiac arrest, and found substantial benefit in their papers to giving this VSE protocol. And that's vasopressin, 20 international units, Q3 minutes times 5. Epinephrine, 1 milligrams every 3 minutes. So basically the same way we usually give epinephrine. And Solumedrol, or methylprednisolone, 40 milligrams IV at the first round of treatment. And then afterwards, they gave a hydrocortisone for the next week to most people. There were a little bit of sort of finicky things with that part of the protocol, but it doesn't really concern us that much in eMERGE either. We'll talk about that in more detail. So let's talk about this paper. So we have a case. This is a real case. Beginning of August, I'm at work. I've brought my 14-year-old daughter to work with me. She wants to see what eMERGE is about. And after 2 arrests already in the case, or 2 pre-arrests, we get this case. 72-year-old arrives VSA, witnessed arrest, rapid CPR initiation, good story for chest pain and collapsed at home. 4 shocks en route, was a 15-minute transport time, had a good EMS crew, good quality CPR en route. No return of spontaneous circulation, but when the patient arrived, interestingly, as opposed to most of these people who have collapsed in the periphery in Elgin County, where there's sometimes prolonged transport times, and they come in looking quite dead, this guy came in looking alive. He looked pink. He was twitching and moving his hands a little bit. He still had either a shockable rhythm, or when he'd go into PEA, we could still see cardiac activity, even though it was weak on the ultrasound. He was giving us some signs that he was different than the guy that we usually just put the ultrasound probe on, call the code, this is it. So we wanted to work hard on this guy. He has a previous cardiac history, but he was living at home independently as well. So here's our case. Now, what should we do to help this guy? What can we do to improve this guy's prognosis? What can we do? Dave?
Quality CPR.
Yeah, so good quality CPR. That is the biggest advance that we have had. And right now, is there anything else that we really do that improves this guy's prognosis, Ben?
It's time to defib, but we're already defibbing.
Yeah, so really, shocking and CPR is what we do. So it's fairly simple right now, okay? So in the 1990s, I'll tell you what we would do. I would stand there and I would tell everyone to stop CPR, I need to intubate, and we would take about 2 minutes to intubate this, and then we'd feel really good about intubating. We've intubated this guy, but he's dead now. But we felt good because we got the tube in. So that's what 1990s were about. In 2001, we would then proceed to giving amiodarone because it was felt to be holy water, and they paid lots of money to have the headquarters of ACLS and heart and stroke upgraded. So we would then give amiodarone. Thankfully, that's gone by the wayside. 2013, as Dave said, CPR. Now, what else can we give this guy? Can we give him epinephrine? Well, we've already reviewed papers at Journal Club that epinephrine may worsen prognosis. Certainly, zero evidence out there for the epinephrine that we all give for arrests. Zero. Right? So vasopressin. So last year, vasopressin, big trial came out in the New England Journal showing that vasopressin was of no benefit. And I was just listening as part of prepping for this talk, I was listening to the emergency medical abstracts tapes where they review the papers, and the person reviewing this one said, we can now put vasopressin to bed. We can just push that out of our brain for cardiac arrest. Vasopressin has no benefit. So it was thought that vasopressin had no role in cardiac arrest after this latest study out of a string of studies that showed vasopressin had no benefit. How many people have used vasopressin in arrest, by the way? Because it is on the algorithm. So a few people have used it. And did you guys, Lisa, I saw your hand up. Did you use it just because you wanted to use something? And you know that something, we give epinephrine, and there's no evidence. There's about as much evidence for epinephrine as vasopressin. So certainly no harm in giving it, but no benefit known. Okay, so there's a whole string of things that we can give. Atropine, magnesium, lidocaine, amiodarone, TPA, bicarb. So all of these things are studied, and none of them have shown in human models with actual real-life scenarios any benefit. Vasopressin has been studied in animal models and found to have supposed clinical benefit, and that's why people keep going back to it, but nobody's found any drugs. So what can we give this man to improve his prognosis? So this is a big paper. Vasopressin, steroids, and epinephrine, and neurologically favorable survival after in-hospital cardiac arrest, a randomized clinical trial. So this is a paper you're going to hear a lot about. This paper was done in Greece, randomized, multi-center trial, and make no mistake, no matter what we hear about the paper, trashing it or lauding it, this is a landmark paper. The floor of the resuscitation literature research room is littered with the dead husks of medications that have shown no benefit in resuscitation of ACLS patients, okay? So this is the first paper that has shown any possible benefit in a real clinical setting of giving drug therapy to cardiac arrest patients. So this is a landmark paper. So this is published in JAMA. So these people took 268 consecutive patients with cardiac arrest, randomized them into two groups, and they found benefit in their study protocol. And that's what we're going to talk about just for a couple minutes. The study design, as I said, randomized, blinded, multi-center, inclusion criteria, in-hospital cardiac arrest. So one thing that's a little bit different than our practice setting is that all of these people arrested either in the emerge, the OR, the floor, the ICU, or the CCU. So slightly different from where we sit. Nonetheless, they wanted to capture people who had rapid initiation of CPR and presumably a better prognosis. Excluded the typical people who you'd want to exclude from this kind of study. They did exclude children, and as we know, children who arrest generally more often have a respiratory cause of arrest more often. Terminal illness, DNR status. If they were arresting from known exsanguination, such as a AAA rupture or trauma or something like that, they were excluded. And because steroids were part of the treatment protocol, if they had been treated with IV steroids prior to arrest, they didn't include them. If they had prior enrollment in the study. So if you were unlucky enough to arrest once in hospital, be successfully resuscitated, and then go back into arrest, then they didn't want you in this study. Outcome measures, return of circulation for 20 minutes or longer. That was one primary outcome. And survival to hospital discharge with favorable neurological recovery. So the two primary outcomes. Of those, which one's the one that is more patient-oriented? Which is, second one, obviously. So, there have been actually plenty of studies which have shown some benefit of medication therapy for return of circulation of 20 minutes longer. So epinephrine does a better job at getting people into our ICU. It's just those people then die a day or two later. It has no benefit when given alone in survival to hospital discharge. So these people said, really, the more important one that you want to focus on is survival to hospital discharge with a favorable neurological recovery. And they use this CPC score, which just the small writing at the bottom talks about it, but it's a scale of 1 to 5, and 5 you're comatose, and 1 or 2 means that you're functional. 1 is you're able to live and work normally. 2 is you're conscious and able to conduct independent daily activities. To go over again, so this is the protocol, and it's actually quite simple. So this isn't a complicated drug therapy regimen for you to remember. Vasopressin, 20 units every time you give another round of drugs in our CPR cycle. So 20 units every 3 minutes, and then the epinephrine is exactly the same as we usually give it, and you give some Solumedrol at the start in the first round of your resuscitative sequence. So rather than giving a milligram of epi, you also call for vasopressin and Solumedrol. And then post-arrest, in the people who were in shock, basically requiring pressors, hypotensive, after their arrest, they then gave hydrocortisone, 300 milligrams IV. That was given 4 hours post-arrest and then daily. This is the part where you're probably not going to remember all of these details of how they gave the Solucortef. But as I said, the Solucortef wasn't given on the initial sort of resuscitative sequence. It was given 4 hours later, just for those people who remained in shock, which obviously after arrest was most people. And then they were then given Solucortef daily for a week afterwards. They tapered them for a couple of days. If you had an MI, they only gave Solucortef for 3 days. So you might wonder, because I wondered, where did they get this idea? Like, why are we giving steroids to arrest? And if you read the paper, and if you read the paper prior to this, so this Greek group, they actually studied this same VSE protocol earlier in the 2000s, and they did a single-center randomized, randomized single-center trial of 100 patients. And they found benefit in that group of 100 patients. They published that in 2008 in the Archives of Internal Medicine. And then as a result of the success of that trial, they wanted to try and duplicate it with larger numbers and in a multi-center format. So that's where they led to this. And if you read that original paper from 2008, they give some rationale for the steroids. So they say that in arrest states, they've measured cortisol levels and they're artificially low. And they also feel that cortisol can improve the myocardial function, and they describe some basic science studies that would support that. So they think it'll improve myocardial function within 30 to 60 minutes, and they also feel post-arrest steroids may ameliorate some of the toxic mediators which are released in stress states, and ameliorate some of the end organ damage that you get when people have arrest. Now, they also did this little switcheroo of giving Solumedrol initially and then Solucortef afterwards, and they have some basic science rationale for that, which I don't think is really based in a huge amount of evidence, but they thought it was beneficial. They mentioned in their write-up that maybe they could have switched it, and it might have been worthwhile. This is the protocol. This is the complicated sort of study flow chart. The results of it at the end of all of this were they randomized 300 people. They excluded 16 people in each group at the start because some people arrested and then came back quickly before they could launch into this whole protocol. And in the standard epi group, 7 were alive at hospital discharge with a good neurological outcome. And in the active treatment group with VSE, 18 were alive at hospital discharge. So that's actually a fairly significant number. So a fairly substantial number of people had improved neurological survival. And they did all the usual things too of cooling people appropriately and et cetera. Any questions so far about this protocol or what they did so far? Yeah, question.
Yeah, probably a silly question. My understanding with vaso is that it's got a super long half-life, like half an hour or so. And so I get the big dose of vaso up front and then you go for the rest of the code. What was the rationale for giving the 20 every 3 minutes?
I didn't find that in the paper as to why they. So you're right. When I've seen other vasopressin papers, for example, have used a protocol of just giving 40 units instead of 20 once or twice, and I haven't. I'm not aware of another group that's done vasopressin 20 up to 5 times. So I don't know. They didn't talk in the paper as to why they picked that particular protocol. I'm not sure. I don't know if anyone else has a comment about that. But you're right that the previous dosing of vasopressin was a little bit different in some of the studies. As I said, this is a landmark paper. So these guys, Oliver and Schaefer, were at University College and were amongst the first people 110 years ago to research epinephrine, including this guy, Dr. Oliver, who apparently took adrenal gland extracts and reportedly, from some reports, injected them under the skin of his son to then see what reaction would occur. that was part of the basic science research in that day. So they would be proud that actually some use has been found. So what do we do now? So we now have this paper that is that dramatically changes our practice. So I'm going to ask you now. I don't know how many people have seen this paper or sort of heard of it, but how many people are giving this VSE protocol? How many people have thought of giving it or seen it given? No one. So, and how many people now, after hearing about it for 10 minutes, are going to start giving it? So nobody's going to start giving it. All right, I feel highly successful in okay. So what do we do? So obviously the reluctance is you should be skeptical about any new therapy. So we have plenty of examples of all these dramatically wonderful new therapies that have been proven in a single trial or from a single group, and then other people go to implement this therapy, and then it's a failure. So we should really be skeptical about this, and I agree with that. So one of our strategies too is it's hard to understand the impact of this paper. What are the other people thinking about it? So let's try some free open access medication, right? So this is now a movement in emergency medicine. All these people do blogs. They all go through the papers. They go through the supplementary protocols, stuff that you and I probably aren't going to do in very often. So let's see what people have to say. So here's one site that Carl sent me. That there's a guy who runs a site called EM Lit of Note. I put the link in there. So he goes through various new papers and gives his own little personal commentary on them. It seems to have a reasonably intelligent. So he says he's concerned about this paper. So this guy says he says despite randomization, the epinephrine group was saddled with quite different causes of cardiac arrest, almost certainly favoring the intervention group. Now I read through their randomization protocol. It was very good. So their randomization strategy was solid. I could not see any holes in it. But nonetheless, he feels that despite this attempt at randomization, the epinephrine group had far more asystole than the combination group. Different numbers of each group underwent PCI. His final feeling is ultimately it's a mess. Now, personally, I think this is a bit harsh. Like having done clinical research, these guys have probably spent 10 years of their lives on this protocol. They've done, it's actually a monumental achievement to put a multi-site, randomized, double-blind controlled trial in a high-risk situation like an arrest together. You're not going to see many people undertaking this. A lot of people had to devote their lives to get this study done. So to call it ultimately it's a mess, I personally think is a bit harsh. But this guy was concerned that there were some issues on this sort of randomization. So this is the table sort of talking about randomization. And if you look at the numbers, if you can see these small numbers, the numbers are pretty similar for each kind of division in the control group and the VSE group. I mean, if you actually look at it, the randomization to me looks pretty good. Now you can see, I've circled the asystole, and you can see that 70% of the control group and 64% of the VSE group had asystole, so there was a 6% difference. That wasn't statistically significant. However, it is certainly favoring the VSE group. Whenever you do a study, though, you are going to have these kinds of small differences in the numbers, and certainly most of those other numbers line up pretty well when I look at it. So I think his criticism was a bit harsh. So EM crit. So we're getting Scott Weingart to come and speak to us. He's Rob Arnfield's good friend. He's got a blog that is or a monthly discussion series that's downloaded apparently 180,000 times a month. So his comment on it was, this study is seemingly a big deal. That was his comment. He didn't say he was a big deal himself. He said this study is seemingly a big deal. So so listening to this study, someone was commenting on it in the blog, in the little comments by readers underneath his own posting about the study. And someone said, they were basically saying, I don't think I'm going to use this for this and this reason. And he said to them, unless you have stopped using epi during your arrest, the guy said, I don't know what to do. And he said to that guy, unless you've stopped using epi during your arrest, then you know exactly what to do with the results. Have you stopped giving epi? Now, how do you interpret what does he mean by that? What do you think he means by that, Andrew?
I guess if you were inclined to not use epi based on the fact that you said that there's no evidence for epi, then this paper should kind of give you some sort of direction as far as what you're doing as far as using the VSE.
He's saying you should use it. So he's saying if you are using epi, how many people use epi when they see someone with an arrest? All right, so I can tell you that there is way more evidence out there for VSE than giving epi. So if you're still giving epi, if you have not been swayed by the literature saying epi is of no benefit in arrest, what he's saying is, if we're still using epi, well, there's way more evidence for this protocol than there is for epi. So if you're using something, if you are using drugs in an arrest, you know what? This has way better evidence for it than whatever you're using. I can guarantee you that. So that's what he's saying. Now, we're going to have, I'm almost done speaking because I want to open this up to the residents and the staff for discussion. Because you're basically going to hear that the trouble, what we want to try and move away from is, in Journal Club, obviously, there's always a difference of opinion. This study is crap. Actually, Shelley just texted me. She was going to be here, but she got delayed. But she texted me early this morning and said, "This study's dog shit." That's what. So I was going to ask her what she meant by it, but so I was going to. So maybe we'll get Carl's nodding. So Carl thinks maybe it's. There is more evidence for this. There are now 2 papers showing the utility of VSE. Now let's think about harms versus benefits too. So what kind of harms do we have to think about when we're incorporating a new drug therapy? What kind of things do we have to think about in terms of harms? What would we think about? Lauren?
Bottom line is this has more evidence than what we currently do. So I mean, if the patient's arrested, it certainly doesn't seem like it can harm the patient.
Okay, so we don't think, so in terms of harm to the patient or chance of harm, at least the study doesn't suggest that more people were dying. Okay, I agree. So in terms of clinical harm, what other things do we use to, consider whether we're going to use this therapy or not?
And from a practical standpoint, I'd be curious to see what the buy-in would be from the staff and to see, do we have this dose of epi available and the nurse is going to be okay with this? Is this going to throw everybody into a tizzy because this is the new protocol? Is this going to create a tornado?
Right, so Lauren's basically saying, I don't want to look like an idiot if I suggest it. The nurses and the staff say, what the hell is Lauren talking about VSE? Then I don't really want to be the first one to be using this, which is reasonable, right? So you have to think about that. Okay, and what else? Yes?
I think as far as safety goes, like we use steroids in so many other situations, we know that it's very safe to use. So giving steroids to a dead patient doesn't seem that unreasonable.
Yeah, so I think Kyle's right. So you really have to think also is how many times has this drug been used? Are we familiar with it? Is it available to us? Are we comfortable with its use? So all of those questions are important. So if we are starting to use Zygris for sepsis and we have never used it before in any other clinical setting, but there's one trial that says it's good, we need to be a little bit cautious. We don't have any experience with it. That's the drug that turned out to be killing people and costing thousands of dollars, So it's been withdrawn from the market. So those are scenarios where we have to be a little more careful. I don't think we have to be so careful. I mean, there's animal data suggesting that vasopressin is useful. There's a mountain of other data suggesting it's not useful in cardiac arrest in actual real-life situations. So that makes me skeptical. But in terms of danger to the patient, I don't think there's much harm. One other consideration then? Yeah.
Well, we have to make sure it doesn't distract us from the stuff that has evidence, like good CPR.
Great point. Great point. So are you using your resources to give something of questionable value and taking resources away from something that has known or proven value? So that's a great point. And when you're thinking about it in this context, you know what? There's usually a lot of people out in rest, and most of us are standing there. So, there's one person doing CPR, and there better be another person standing behind them who's ready to do CPR, a lot of activity going on that is going to be redirected by drawing up these things. Yes?
Also,
Ben.
just considering too that we might be the ones giving that first dose of steroids, this also, according to the protocol, has to be continued up in the unit, so you have to have cooperation between both us and
Right. Yeah, so you'd have to have some communication, and any of these things, it's interesting how long it took to, once we had the really good evidence for cooling, now I think all of us automatically think about cooling, for example. But I'll tell you, when it first rolled out and working here and in a community hospital, it took some time to get buy-in from everybody, from the staff down here, the staff up in the unit, and all the the nurses who actually do the work of cooling people and that. It took quite a bit of time to get buy-in. So yeah, you need to get buy-in. Now, is this adding much work to people? No. And the other thing is, the drugs are easily available, so they're around. And another big consideration is they're cheap. So, who's getting benefit from this too? If this was a drug company-sponsored trial, I would even be much more skeptical. But these are all cheap drugs that no one's making any money off of, which actually gives me a little more faith in the trial.
Can I just ask a question about that? When vasopressin had its brief up and down, I vaguely remember people being very happy to yank vasopressin off the carts very quickly as soon as those trials came out, and I thought it was a cost and availability issue.
Oh, yeah.
I thought vasopressin was maybe just relative to epinephrine, which is
it's quite pricey compared to it.
It is pricey, isn't it? I think vasopressin is.
Do you know what all the cost actually?
I originally it was around $30.
For like a one.
It was like, because I know, because there's 180 crash carts in the hospital, and I know it was a huge cost issue to stock it or not stock it. And like, there was 7 trials at that point, none of them had benefit, so we yanked it. I don't know what the cost is right now, but it.
I think there were some supplier issues.
Pennies, right?
There were some supplier issues.
Interesting. So cost may be an issue, and currently we don't have vasopressin on our crash carts. Is that correct? So would this make you reconsider that decision?
No, and I look at their survival numbers. Like they're only getting 10% in hospital survivors of cardiac arrest, which I remember here is higher than that. I thought, right? It's
a non-optimized system.
and yeah. What's your pre-hospital survival?
It's 5 to 8% more than pre-hospital.
I think in-hospital is 30%.
Yeah, it's much
So
higher. So these numbers are
these numbers are way under our numbers initially. So what I would do is fly those people over here.
This is also pretty harsh. Some of the commentary, Scott Weingart mentions it in his little podcast about this, it's only 3 minutes, that he talked to other sort of resuscitation experts in the field, and they said, the survival numbers are quite a bit lower than what we have here already with our system. At the end of it, though, I'll tell you, Scott's final comment is, I think I'm going to start doing this. Yes?
So, having sort of sat around for 25 years looking at resuscitation things that come and go, that's often what happens, though. People see 1 or 2 papers that are small. The one group was six patients. Now, I'm sure that's why Shelley was calling it what she did, because if you got down to close to 4 patients, then it's not, really you can't analyze. And so what happens is you get something like this, and then people, sort of jump on a bandwagon, think it's reasonable. And then you do the bigger study, which is, you need to have a bigger, higher powered study before everybody jumps on this bandwagon, I think, because I don't think this is going to do it, especially when it's already way under our resuscitation rates here. So you have to just be a little bit careful, because you see it come and go. Same in the guidelines. It comes, it goes in, and then somebody else does something 2 or 10 years later, and then it's out. And that's sort of what happens.
And we've seen this with multiple therapies. Yeah. So you see, you're right. Over time, you see. Nonetheless, we now have things like, as I said, cooling, which if you look at the numbers in the trials in terms of the actual people studied in that, we're starting now to get into a critical mass of numbers where this needs to be replicated in a larger scale. But they already have now 2 studies from one site which are positive on this. So this is, as I said at the start of the talk, this is actually so far the best quality evidence that's come out for a drug in resuscitation. Now, the one huge consideration would be the cost of the vasopressin, because this, as you said, if you're stocking 140 crash carts in the hospital, it becomes a big deal if you start to put that back on, and you have to really look at cost-benefit analysis. So that's a big consideration in this.
It's $13.99 a 20-unit vial.
Oh, thank you. Yeah, perfect. Yeah. So
I get
so
18 bucks for 40 units. But
There you go.
I got a better deal.
So part of the, oh, you guys aren't bidding against each other then. You're just giving us the prices then. Is that? So this is another. So this is one other. We talk about foamed or free open access medication, and when you're faced with this onslaught of new papers coming out every month, when you're in your residency, when you've graduated, Emerge is one of the areas where you just have to try and keep up to date, at least with what's going on. So Journal Watch is one of the things that I subscribe to. So it's not free, but it's $99 a month, or $99 a year. $99 a year. And so they also reviewed it actually just a couple of days ago. And their conclusion, their reviewer said this study represents a new milestone in interventions for cardiac arrest, a pharmaceutical combination that affects important patient-level outcomes. So this well-designed study warrants review for incorporation into cardiac resuscitation guidelines and clinical practice. So it warrants review. So they're not saying it has to be incorporated, but I also think those of us who've been around sort of long enough to see that trend that John was talking about, where you see a study and then it kind of goes nowhere, and then the next study disproves it. We also have to be careful not to be over-enthusiastic, but we also shouldn't be really blasé about this finding. This is a landmark study that, if the replication study also shows this, is going to completely change our practice in arrest, and we should be aware of it.
How can you say it's landmark when their survivals are terrible?
Well, I think, as these guys say, that there hasn't been a RCT. I mean, this was a very, very well done study in terms of design. So the design of the study was the highest quality you can get. And even though, so their survival rates may have been poor due to other factors, and I agree that it may not be the rates that we see. Nonetheless, they had a substantial number of asystolic patients, for example. They had a huge number of asystole as their presenting rhythm, right? You saw that it was around 65 or 70. Well, if we had, the reason we get better survival rates in hospital is because we get people found sooner. So, for example, if you just thought that their nursing sort of surveillance of the patients wasn't as good as ours, and they're finding people who are arrested later, they're going to have a whole bunch of people who are just non-salvageable at the start.